Welcome to this edition of EMS Journal Club. Dr. Bobby Goyle, one of our fellows, is going to be leading November 15th, 2023. And Dr. Goyle, take it away.
Sure. Good morning, everyone. My name is Bobby Goyle. I am an EMS fellow at Rutgers Health, RWJ Barnabas at Newark Beth Israel. Also formerly a paramedic in New Jersey. Um, so the article we're going to go over today, basically it comes down to, bigger doses of ketamine, do they cause bigger problems? Right. And the article itself is association of ketamine dosing with intubation and other adverse events in patients with behavioral emergencies. So this was first published in Pre-Hospital Emergency Care in July of 23. The research was conducted by the folks over at UT Health Science Center in Houston, Texas. And so basically, what they did was they used the ESO database from 2018 to 2019 and their data set from there. For those who aren't aware of what ESO is, it's Emergency Service Operation Solutions. It's a private company. They offer, a suite of software to fire and EMS services to collect data and improve their operations, based on that data. So they, have an enormous amount of data that they gather nationally and create a free data, public database, to access and to conduct research. So the researchers used that data set to identify 2,383 patients who received pre-hospital ketamine for agitation at what was called the consensus dose versus the high dose. So the consensus dose is based on an article that was published in 2020. It reflects the position of several medical authorities on the safe dosing of ketamine. These organizations included the American College of Surgeons, the Committee on Trauma, the National Association of EMS Officials, the National Association of EMS Physicians, and the National Association of EMTs, who basically all sat down together and decided on safe dosing for ketamine. Um, all right. So, going into the article, our PICO questions. So the population was essentially anyone greater than 18 years old who was atraumatic and had a behavioral complaint somewhere, on the chart, and who received IV or IM ketamine. The exclusions were intranasal ketamine. The reason for that was because intranasal ketamine is not on that consensus dose list. So it's outside of the purview of the study. Trauma, people who were missing weights because it was a weight-based dosing. Um, People who were missing vitals and anyone who's reported at greater than 120, which oftentimes is a placeholder for patients who don't have a known age, but those that group was also taken out. The intervention was the high dose ketamine, which is a dose greater than 2 milligrams per kilogram IV or greater than 5 milligrams per kilogram IM. The comparison was, the low dose group, or they also called it the consensus, dose group, which we talked about earlier. The primary outcome was intubation, patients that need to be intubated. And they also included those that required a supraglottic airway. So it didn't have to be traditional endotracheal intubation. Anyone that needed a more advanced airway was, put into that group. The secondary outcome was respiratory intervention, and that also had included, the subgroup analysis of the intubation group. Improvement in agitation. So those patients who were marked somewhere, on the chart as having improved from the administration of ketamine. Hypotension, which was a blood pressure of less than 90 systolic in patients who started off with a blood pressure greater than 90 systolic. People who required antipsychotic therapy on top of ketamine, so the people who got Haldol or other antipsychotics after they received ketamine. Those who became hypoxic, at less than 90%, and patients who went into cardiac arrest. The author's conclusions were patients presenting with undifferentiated behavioral emergencies given ketamine doses above the consensus guidelines for sedation in the pre-hospital setting appeared more likely to receive pre-hospital intubation. Um, did the study address a clearly focused issue? Yes, basically, yes, all the way down for our observational study checklist. So getting into the tables, when they pulled the original data set, they started off with more than 14 million EMS encounters, and this is, nationally over, the 2,000 or more EMS agencies that use the ESO software. They excluded 14, they excluded a large number, essentially, who did not receive ketamine, which brought them down to about 24,000 patients who received ketamine. Of those, 20,000 were not behavioral emergencies, and 435 were traumas. So they, then ended up with 3,100 who received ketamine for behavioral emergencies. A significant number of those were missing weights, blood pressure, respiratory rate, GCS, things that were being evaluated in this study. Ultimately bringing the number down to 22,383 who received ketamine, with 1,905 receiving the consensus dose or low dose, and 478 receiving the higher dose of ketamine. This table just showed the distribution of how ketamine was administered, and the dosing. So in the IM group, most people received the consensus dose for IM ketamine, or a little below, with some smaller numbers of patients receiving much higher doses. Same thing with the IV group. Most people received at or below the consensus dose, which was 2 milligrams per kilogram, with a few people receiving much higher doses, including twice or nearly 4 times the consensus dose. The tables going through them, the median age was 36, in the low dose, 34 in the high dose. So the characteristics were fairly simple, or similar rather, in the two groups that were studied. So going to the results. So essentially, it was a wash when it came to any respiratory intervention between the consensus dose and the high dose group. However, in the subgroup analysis, for intubation or supraglottic airway placement, nearly double the number of patients needed to be intubated or received an advanced airway. With the odds ratio being 2. Um, Outside of that, most other of the outcomes were essentially similar between the two groups. So while those who received high dose ketamine required more intubation or supraglottic airway, um, they didn't see much of a difference in the two groups in terms of the other potential problems that you may have as a result of ketamine dosing. All right. And then ultimately, I think this is applicable to, all EMS agencies that use ketamine pre-hospitally for agitation. I think that if, I'm going to give advice based on this study, it would be that if you're going to use ketamine, you should stick to the consensus dose for the lowest rate of airway adverse events. Now we can take any questions or comments.
Anybody have experience with some adverse events with the ketamine?
I'm sorry, can you repeat that?
No, I was saying that has anyone have had any adverse events with the ketamine? So a lot of the times with ketamine, especially for depending on what you're using it for, when you're looking at airway adverse events, usually the problem is if you go too low, not necessarily too high. Also, going IV instead of IM or IN, so intranasal or intramuscular. You can't give that high dose that you would normally give intramuscularly IV. And then also not relaying the information appropriately or the emergency room receiving the information appropriately that you gave the person medication such as ketamine.
It's interesting that you brought up the too low dosing. So, there is that thought that there's sort of like a danger zone for ketamine dosing between the pain dose and the sedation dose of ketamine. It was kind of interesting that you had some people that fell into that lower dose group, but they didn't really see too much of a increase in adverse outcomes in that lower dose group.
Yeah. The other thing is where you get some of the adverse events is when you redose. So I'd rather give someone a higher initial dose and not have to redose than have to give multiple doses of a lower dose. And now I don't know how much is on board, how much isn't on board, that sort of thing like that. Or even switch into another agent.
Yeah, I agree. It's probably safer to switch to something else than redose with the ketamine.
Yeah. Were there any other any trends that they noticed when they were using this?
So, in the article itself, they only other trends were that when you look at the other adverse events associated with ketamine administration, there was really no difference in the two groups outside of people need to be intubated. Um, what would have been interesting to see, so they have that non-invasive intervention group, which includes people who had to be bagged. Um, it would have been interesting to see if what the time difference was between the intubation group and the BVM group. If the people in the intubation group just need to be bagged a little bit, and they would have avoided the intubation.
No, no, absolutely. And think about it from your own experience. Sometimes you see someone and they're a little bit altered. They're maybe a little bit confused or the lethargic, right? But then after it's like, oh, they got 300, 400 milligrams or something or even 500 milligrams IM of ketamine. And you're like, oh, okay.
Yeah.
But the important thing is, what was their exam before the ketamine was on board? If
Yeah.
the exam was before, they were combative, they were fighting. Now their pulse ox is fine. They're a little bit lethargic, and you've been monitoring their airway and their blood pressure has been fine. That's a much different than someone coming in looking lethargic. There are some places that when they were given the ketamine, they actually wanted to actually take a marker and write K on their forehead. I vote against that. Just a good patient report and making sure that the receiver understands what the report was.
Yeah. That's like the old World War II thing where they used to put M on, people who got morphine.
Yep.
Um, yeah, so I mean, again, kind of piggybacking on, what you said, and what we, mentioned earlier, it's kind of like those people who would do, procedural sedation on in the ED and they get propofol, and sometimes very rarely, they stop breathing, you bag them through it, and then a few minutes later, they're, okay. Um, so again, it would have been nice to see if the patients who got intubated, if they could have just been sort of back through it, and then ultimately would have been okay on the other side of it.
Yeah, that's a subgroup analysis. We can even look at that ourselves. But for the most part, being ready for those adverse events is more important than, not using the drug itself. Like
Yeah.
use it for what it's there for. Just be ready to address these adverse events if they should happen. All right. If no one else has anything else, we're probably gonna skip December, but I will send out an email depending on what dates we're gonna discuss it after this meeting. The next journal club's gonna be. And if not, we'll probably see everyone after the holidays. Well, so yeah. All right.
Sounds good. Thank you, everyone.